Welcome to our 8-week Family Caregiver Education Series, hosted by the Central Okanagan Hospice Association in partnership with Vantage Living and Jumpstart Communications. Through challenging times, and especially during this pandemic, we know family caregivers are carrying more responsibilities in caring for their loved ones, carrying more stress with varying restrictions in place, and some having to make some life-changing decisions to be closer to their family. Through this 8-week Caregiver Education Series, we hope that family caregivers will be able to build confidence, resiliency, skills, and learn more about self-compassion and self-care. We call this filling up our toolkits. The Central Okanagan Hospice Association has been providing supportive care programs and services to individuals living with a serious illness and supporting their families along the way for 39 years. This may be through our community hospice visiting program, wellness program, vigil services, or providing grief support. Our programs complement the medical care to bring an integrated approach to palliative care by providing emotional, social, practical, and spiritual supports with trained, compassionate, and dedicated volunteers and our professional staff. All of our services are offered at no cost, so there are no barriers to access our services when and where needed, thanks to the generosity of our community. The Koha Aga Center is located on Cooper Road, and we have a lending library full of resources and great reading materials for family caregivers. Today's topic is managing pain and symptoms, presented by Tara-Lee Calhoun and Mark Percy from CareX. Tara-Lee is responsible for clinical oversight and program development for all Vantage long-term care residences. Tara-Lee has over 34 years of nursing experience as a registered nurse. She is unique in having worked her nursing career in acute care for 32 years, but truly found her passion in caring for seniors by leading the nursing teams for the past 24 years in long-term care. Although Tara-Lee is often on site supporting the clinical teams, Tara-Lee's primary work location is at the Kelowna corporate office. Her past experiences as the Director of Care in long-term care for over 20 years, she has provided strong nursing leadership and ensured best practice outcomes to enrich seniors' lives. Since 2013, Tara-Lee has achieved her gerontology certification through the Canadian Nursing Association to better lead the nursing team in providing the best care for our seniors.
So welcome everyone, and good morning, and thanks Natasha for that warm introduction. My session today is on managing pain and symptoms, and I'm fortunate to work with the pharmacy that Vantage Living works with, which is CareX Pharmacy. So Mark will be doing the second half of our presentation today. I did doing some research on this. I found this really great supporting document by Vivian Fraser, and it's Caregiving is a Constant Learning Experience. And it has some really good knowledge, and it's easy to read and very uplifting and supportive, and some great ideas for caregivers. So I really thought that was a good resource for you. So what are we going to cover today? So today we're going to cover, review what is pain. I covered that in our first session around pain, but I just want to cover that again. Pain behaviors and what to be looking for, how to use some pain assessment tools, and how to best handle the most common physical symptoms that caregivers may encounter as your loved ones are declining or getting older, and how to best handle some of the side effects when you are using pain medication. And then Mark is going to be covering the traditional medications and some information around cannabis use or marijuana usage. So I found this really amazing quote from Barbara Kingsolver, and it says, empathy is really the opposite of spiritual meanness. And it's the capacity to understand that every war is both won and lost, and that someone else's pain is as meaningful as your own. And that's what makes us caregivers and Empathy is a wonderful thing. And as your loved one could be having some discomfort or not feeling comfortable, you take that on yourself. And that shows that you're being empathetic and caring. And that takes a toll on your mental health, but it also shows that you're a caring, loving person. So it's okay to support your loved one and struggle as they struggle, because that's what makes us human, and that shows that we're truly being empathetic. So I wanted to go with the definition of pain just to help us. So it can be localized, or it can be very general throughout the body. It can be unpleasant sensation. It can be complex of sensations. It's not just one thing. It can be mild to quite severe at times, and it is a physical discomfort, but it also affects our emotional distress over it. And typically that results from a body disorder. Usually it could be an injury that could be acute, or it could be from a disease process. So I just wanted to help us understand what pain really means. And it's what the person believes it is what truly matters. So let's look at pain behaviors. So we are the detectives in this world. As a caregiver, you're always assessing and thinking and guessing what's happening, but it's your eyes and your ears that's really going to tell you what's happening. So pain behaviors can be verbal. You can have verbal descriptions of intensity. Oh, it's really bad today. You can be the location. Oh, my back. It can be the quality of pain. Oh, it's really throbbing. Watch for those key words. Those words are what people, when you ask them, describe your pain, they go, I don't know. But then they're like, oh, this really is achy. There you go. It's achy. That's a way to describe it. Watch for vocalizations of distress. You'll ask them, it's time to get up. Are you having any pain? No, I feel great. You watch them get up and they're like, oh. So watch for that verbal communication. Watch for the good old moaning. That is a really red flag and easy for you. Watch for the complaining. It's like, oh, it's really cold in here today. Oh, I'm so cold. This room's cold today. It might not be about the room. It might not be about the cold. It might be about the pain. So watch if they're complaining about something that you think, well, this room can't get any hotter. So maybe it's not about the room. Maybe it's about their pain, and that they can't vocalize and say, you know what, my pain's really getting worse. Watch for the nonverbal. So it is your eyes and your ears. It's your senses that's telling you what's watching. So watch for withdrawal from activities. Hey, Mom, let's watch our TV. We always love watching this program. Oh, I don't feel like it. It's the detective in you to go, why? That was normal. They enjoyed it before, and now they're not. Could it be that pain is actually on their mind and they're not able to focus on something else? Watch for the good old body postures. When we're painful, we'll hold that area. We'll rub that area. We'll bring our hands in. We're not loosey-goosey relaxed. We're tense. So watch for that. Facial expressions is your number one clue. When you're turning someone, helping someone with care, it's watching the face that will tell you if they're having pain. Are they scrunching up their face? Are they scrunching up their eyes? Are they gritting their teeth and locking that jaw? So watch for that loose, soft face, or that face that's showing tension. That's a sign of nonverbal that the body's having pain with movement. So I want to talk about some pain assessment tools. Not that you have to have a tool in front of you. It can be just a verbal, but having these tools really will help you whether what you're trying and working on is actually effective in the pain control of what you're trying to achieve. So not only does, not only does controlled pain, So not only does controlled pain improve the patient's comfort, it also improves other areas of their health. So what's really tied together, if I'm having pain, it is my emotional well-being that will be struggling with it. And watch for my ability to move. If I'm having pain, I don't want to get up. As much as I have to go to the bathroom, I don't want to get up because I know it's going to be a painful experience. So my emotional well-being of the level of pain that I'm having can absolutely affect my level of pain that I'm experiencing. Sorry. Thank you. So here's one of our pain assessment tools. This is an easy one. You can have it printed off, or you can just use it and go, are you a happy face? Does your pain feel happy? Is it green? Are you feeling more in the angry level and the painful level of distressing or intense? It's more like a yellow or an orange. Or is your pain level getting really bad? Is it getting to a hard orange or a hard red? So we use the 1 to 10 scale in everything we do. It can be the pictures, it can be the colors, it can be the size of the faces, but you could just ask, Mom, the last time I talked to you, you said your pain was a 2, but you didn't want anything. It was just mildly discomfortable, but it wasn't affecting you. But where are you at now, Mom? You were a 2. It's reminding them where they thought they were the last time. It gives them that springboard to go, okay, well, last time, yeah, it was a 2. Actually, yeah, it's getting worse. So it's got to be higher than a 2 now. It helps them figure out what number they should pluck on it next. What's really important about me telling you about my pain is you have to believe me. Even though I might be looking really relaxed and I'm like, actually, it's a 4. You don't go, well, Mom, you look pretty relaxed. I don't think it's a 4. No, you always agree with them. And what I believe is my pain is my pain. I have a very low threshold for pain. So I might always start at a 3 because I don't like pain. So I might go 3 is, ooh, not very comfortable. My husband has the lowest threshold. So he might go, I'm a 6 and it's fine. So it's all in what you interpret, and what I believe is my pain is what's really important to listen to. So I really like this scale. It's one that I recommend that you print off or use. It has the same concept. It's the same colors. It's the same numbers, but it gives them ideas. Because if you say it's a 5 and they're like, well, what does a 5 look like? Well, a 5 is, I think about my pain most of the time. I cannot do some of the activities I need to do each day because of the pain. So that gives them a basis of, okay, well, that's what a 5 looks like. Well, I'm not quite there yet. Okay, so maybe I'm a 3. Well, what's a 3 look like? A 3 is I'm uncomfortable. My pain bothers me, but I ignore it most of the time. So it's there, but it's not affecting me to do other things. It really helps to understand this level. When you're talking about pain management, I'm a firm believer that you need to, as a caregiver, you need to start working on that regime when they're a 2 to a 4. You don't want them getting up to a 5. It takes forever to get them back down to the zone of comfort level, which is between a 2 to a 4. When you're dealing with some cancer, as I said, only 50% of the people actually have pain. Many people die without pain. So that's a really good thing. I love to be in the 50-50 level. So that's okay. But if you're in that 50% that is having pain, you want to be on top of it all the time, and you want to start working on it. When they're at a 2, which is, I have a low level of pain, I'm aware of my pain, only when I pay attention to it, that means that it is there. And they still have the mental capacity to think of other things and do other things, but that still means they're having some pain. If you took care of it now and you did a low dose, you get them comfortable so it wouldn't be climbing. But when you start to get up to the 4s and the 5s, when it's starting to be distracting, it's going to take them a lot longer to get back down to the 2 level or a 1. So I hope these scales are good, and we will be sharing these PowerPoints so you'll be able to find them. You can Google these, they're out in everywhere, you can find them. But the 1 to 10 is a great tool, or the color zone. So the greens are the happies and the yellow and orange is starting to get uncomfortable. And you really want to work hard if they're getting into the light orange colors. So about pain scales, it's really important to utilize some kind of scale, some kind of program, some kind of color to really help you assess if what you're doing for the pain is actually being effective. A journal is the best way to track. So yesterday we did pain medication. You said you were a 2. I gave you pain medication. I checked later. And you're like, you know what? It's a 2. That means it was effective. It didn't climb. It didn't get higher. So you're like, okay, what did I do? I gave this dose at this amount of time, at this time, and they had a good day. Okay, great. So it really helps that journaling. When you go to see your pharmacist or your physician, it's really important about your journal because honestly, they won't be able to read everything you write in your journal, but highlight some key things to go, I really have a question about this day. This day, here's all the things I did without using medications. Here's all the things I did with medication to try and control their pain, but it was a rough day. We really had to work hard to get it under control. Here's what I tried. And by having that highlighted section, they can go, well, here's an example, is that you gave a 5 milligram dose, but it really wasn't effective. So you tried another 5 milligram dose, but your range was 5 to 20 milligrams. So maybe next time, instead of, you started with a 5, which is great, but next time maybe try a 10 milligram, double it up. If the 5 didn't work the first time, another 5 might not work. So you might have to go to a 10. They'll be able to give you that example by using your journal and showing you some ways that you might be able to handle it when you're having those tough days again. So journaling is a great way to do it. So how do we best handle the common symptoms? So not only is this around chronic pain, but it also could be the average person that's getting elderly or someone that they're having more end-of-life issues. Common symptoms is what you have to do with. And as I said, you're the detective. You're always watching this. So interesting is my brother-in-law just had his knee surgery for the very first time. Hasn't had surgery in his whole life, and he's now in his early 60s, had his knee. So I had to have the fun conversation with him to go, let's talk about constipation. And I had that look going, she is such a nurse. But it's true, we're the detectives. We want to know that, is this body function working well? Because all it takes is a bit of constipation to cause everything else to cascade around that and really be a trouble. So being really proactive and monitoring as you're journaling is going, okay, and we use a cup system. Was it a 1 cup? Was it a 2 cup? And asking, you could just ask and go, was it really loosey goosey? Was it very firm and hard, pebbly? Describing it will help you know what medications you might use. So using a stepwise escalation of medications is a great way to go. Senecot, Colace, common stimulants that can help the bowel to keep going and stay soft. That's what your goal is. You don't want loose, you don't want pebbles, but you want soft. Lactulose is another great thing. What it does is it pulls in the water. So if you have someone that's drinking really good, lactulose is a good laxative to use. If you've got someone that you're struggling with getting fluids in, I'd stay away from the lactulose because all that's doing is pulling what fluid they have in the body into the bowel to try and get the bowel to work. So you got to drink a lot to use the lactulose. And you want to be using these medications when you're using any of the opioids, which happens to be Dilaudid or hydromorphone or the fentanyl patches. So the moment you start on these stronger pain medications, you always want to think bowel care with it. Your pharmacist is going to tell you that. Your doctor's going to tell you that, to always watch when you're using stronger pain medication, to always watch the bowels, because unfortunately, stronger pain medications are constipating. So another medication that is good to use is Relestor. It's not one of the more mainstay ones, but if you're having problems that you're running out and the Senecots and the lactulose isn't doing it, you can try another medication. Your pharmacist is the best person to work with to go, okay, I've used this, it's not working. What else should I be going? You don't want to have to use suppositories or enemas if you don't have to, but you don't want to get constipated. If you're constipated, you don't want to put anything in the system. And you're always worried about dehydration and not eating enough and malnutrition, but it all could start from good old constipation. So many people are worried about sedation. I talked about that in my other presentation. Pain control is more important and being comfortable than worrying about oversedation. We always use the old adage is go low, start low, go slow. And use other levels for pain control, as we talked about, such as a heating pad, such as a back massage, calming music. There's many things, distraction, many things you can use to help supplement pain control and not worry about oversedation. So let's talk about itchiness and sweatiness, which unfortunately many medications cause itchiness. They do. They can cause the body to work harder and cause sweating from that. So it's really assessing what's causing this. Is this because I just introduced a new medication and I'm watching the side effects? Is this the disease process that could be doing this? And this is the body's way of handling it. Many people that have problems with their liver will have a lot of problems with itchy skin. So is it the disease that's causing it? If it is medication and you figured it out, hopefully you have a rotation that, okay, instead of using just the Dilaudid medication, maybe I'll switch it over to morphine and see if that has less itchiness, because nothing is more irritating than feeling itchy. So use lots of body lotion. Every time they wash up, use lotion, keep that skin moist and supple. It'll really decrease the effectiveness of the itchiness. Delirium and confusion. So yes, this can happen. Typically, it's why. If this is your loved one is doing fine and all of a sudden they get really, really confused, that's a hand up to the doctor right away, because that could be a delirium. That's something that should be treated right away. Typically, that is a cause, is an infection. So look for the bladder. Is the urine getting smelly? They're not voiding enough. Do they have increased urgency and frequency? Is it a bladder infection that could be causing the confusion? But also watch for the chest. Are they getting more gurgly? Does it sound like they're rattly? And those could be the ones that are actually causing the confusion, and not necessarily the medication, but it could be the other side effect. The number one cause of increased confusion and or delirium is good old dehydration, and which of course dehydration turns around into bladder infections pretty quickly. So keep an eye on what's happening and what could be the cause, and not let your loved one just go, well, I think it's that pain pill. That's what's causing it. Might not just be that. It could be, but that's where you want to have a really good conversation with your pharmacist and your physician to help you with that. Nausea. Typical, I'm going to say high percentage, over 90% of the lovely meds we take in our life, side effect number one is nausea and vomiting. All you have to do is read any medical journal. It's the number one. So unfortunately, it does happen. Typically with a stronger pain medication, some people can get nauseated. What you have to let them know is that this will settle down. Typically, within the first week of taking a stronger pain medication, they're going to feel a little nauseated. They shouldn't be vomiting. They should just feel a little nauseated. Let them know that, look, let's keep working. This is going to pass. It typically does with a stronger pain medication. But always rule out that number one, is it constipation that's causing the nausea? Again, nothing is more uncomfortable than feeling bloated and having your bowels really slowed down, not wanting to put more food in it and causing nausea. So keep an eye out on constipation. One of the best medications now to take is Maxaran. We have all grown up and thought Gravol is the number one treatment. Unfortunately, the problem with Gravol, or the other name is dimenhydrinate, causes more side effects, can actually cause more confusion, can actually cause risk for falls, can actually cause sedation, and it doesn't necessarily control the reason you're taking it, which is nausea. So too many people are taking that medication for other reasons. It does help people sleep. But it isn't the number one treatment anymore for nausea, Maxaran. You do have to go to your doctor and get a prescription for it in Canada, but it is a great medication to try for good old nausea. And of course, when you're taking it, you want to take that before you eat, and that stomach settle down and move things, and that's what it does. It moves things through the system, so the Maxaran can actually settle down the nausea. So I just want to go over a few summary things from my previous session, and this one is ask about pain. We are the detectives. You want to ask regularly. Before you know they're going out, you have to go to a doctor's appointment and you have to get ready and get dressed and all that. Assess the pain at the beginning. Assess that, take care of that, so when they have to get up and moving, do a lot of energy that you've looked at it. And they might go, I feel fine now. You remind them, we're going to do a lot. This is going to be taxing on you. So please, let's take something now. It can be a small dose, doesn't have to be a big dose, but encouraging them to stay comfortable. and assessing it systematically. It's like, okay, Mom, yesterday it was this morning it was a 2. How are you feeling now? Reminding them where they were at and how are they feeling now. Watch systematically, watch that face, watch the body movement, watch for irritability, you're the detective, and try and figure out what they're not telling you verbally. Most importantly is believe the person's report of what they say. If I have a low pain tolerance and I tell you it's a 4, it's a 4. You can't go, I don't think it really is a 4. How could it be a 4? You believe what I say it is. So always believe what they have. And then if it's a 4, you want to get them back to a 2. So you go, okay, it was a 4. How are you feeling now? And choose your appropriate pain control options. So last time we talked about all the things you can do that are not pain medications, such as massage and music and therapeutic touch. All those things help. But when you're going to pain control, go slow and start low, okay? Deliver interventions in a timely, logical, and coordinated fashion. That's where your journal really comes in, because you're going to be busy. You're making meals and you got to clean the house and you got to do this and you got to do that. And then you go, when was the last time we took something? So writing it down is the best way to not forget when was the last time. Always consult with your physician or your pharmacist on treatment options and treatments for side effects of pain control meds. Every medication has a side effect. That is reality. Doesn't mean that you don't want them to take it. So someone might try a medication, go, oh, that made me feel horrible. I'm never taking it again. Well, did we start really low? Did we give it a chance? Can we drop the dose lower? What can we do? But pain control is more important than maybe the side effects. So let's just take care of the side effects. So that's my presentation for today. I am going to switch it over to Mark. I will stay on for question and answer period with Mark. So I want to introduce Mark. Mark is with our great pharmacy, CareRx Pharmacy, and he's going to be talking about traditional pain medications, but also untraditional pain medications such as cannabis or marijuana. So I'll hand it over to Mark now. Thank you.
Thank you, Tara Lee. Appreciate it. Great presentation. I really love the piece about detective. Pain is different for everyone, as Tara Lee mentioned, and more than anything, trying to communicate effectively to your care providers and for caregivers as well is one of the difficult pieces to make sure that we're assessing and then addressing the pain accordingly. Can I get the next slide, please? So one of the main aspects I want to reinforce is that pain is individualized, similar to what Tara Lee mentioned. Really having a mechanism where you can communicate effectively, whether it be through a journal and also using scales or whatever else is reasonable for the exact situation, really helps to make sure that we create a plan that meets needs. It's also important to note that I'll give off the offset is that letting patients know and caregivers know that it's rarely possible for pain to be a 0. If there is a chronic pain or a new diagnosis that's come on that's causing pain, just the way the medications work, it's always a balance between side effects and pain relief. The side effects are actually a known mechanism what the medications do. And so if you give too much, the pain might go away completely, but there'll be sedation. So creating a plan that we know for both sides where there's a goals of care, knowing what people hope to achieve, what activities we want to do is really important. In addition to what Tara Lee mentioned, just for the journal, understanding these different parameters of pain control, I think is really important. So onset of pain, when did it start? Was it immediate or has it been gradual onset? In the case of a new diagnosis like a cancer or something along those lines where it's causing a new pain, really trying to categorize it and deciding what kind of pattern it follows is really important. Are there certain things that brings it on? Certain activities that your loved one loves to do? Are there certain things that make it better? So for example, if you know that a certain activity is really important, can we create a plan to allow them to do it comfortably and still enjoy? Just because different mechanisms in place and whatever pain level allows them to do it could be different, but knowing that that's important and how we approach it is very important as well. Or if we know if we do the activity, if we rest for a couple hours afterwards makes it better, it's also important to note. Identifying the type of pain or the quality of pain, similar to what Tara Lee mentioned, is really important too, because it can signal for different ways we want to treat it. If the pain is a dull ache or within a joint, or a sharp shooting pain with certain motions versus numbness or tingling or a burning pain, those all signal to care providers that it could be a different mechanism or a different source of pain. And there's different medications that can be used to treat it accordingly, versus just saying it's pain sometimes can be a problem because we may not be using the right tool to actually treat that pain. Localizing it as well to what area can also identify additional assessments, see if there's things that can be done more locally instead of systemic treatments. So instead of giving a pill by mouth, could be possibly given injection over time, and also see if it radiates, just because that could be a more central. Sometimes pain comes from the spine, sometimes the pain comes from the actual area it's coming from. So a radiating pain can signal some different things to a care provider versus a pain that's always in the same spot, never moves. The descriptors, the 1 to 10 scale that was color coded from Tara Lee, is also very effective. It gives a tool to communicate similarly what people actually feel that pain is. And beyond that tool, quite often what I'll use is a generalized approach, where if it's from 0 to 5, that it changes the approach of the way you do things, but it's still manageable. Above 5 to 10, you start changing the way you do things, or you're unable to do certain activities. And so knowing those two sides of the scale, or at least a means to communicate that both sides are communicating the same thing, really helps to decide to what end we want to get to. Quite often when you start pain control therapy with a pharmacist, a physician, they'll talk about where pain is right now, what a reasonable goal is that we can get to, and what are some of the tools for us to get there. Creating a reasonable target that both sides kind of understand in advance also creates some satisfaction, because if, like I mentioned, if the goal is to get to 0 or no pain, and in some situations that's completely impossible, people will never be happy. They'll always be searching for more. And then it also makes it harder psychologically to move forward. So understanding those scales and what you're trying to get to is reasonable. Similarly with the treatments, understanding what's been tried in the past, how it was tried, and then the side effects, whether or not they were reasonable or if they were just not feasible, are something that people is good to express. Quite often I'll see on people's profiles has an allergy to morphine or allergy to hydromorphone. And quite often they're not allergies. Quite often they're side effects that the patient felt were unreasonable, and then therefore will never use them again. We also might find that the way they were started or how they were used was improper, and therefore we're eliminating a potential tool that could work well for a patient. And it's just because things haven't been communicated appropriately. So understanding what the benefits of a medication are, how it was approached, and really documenting, if you are starting and stopping, how it was approached to caregivers, because the more tools we have in our toolkit to approach and help patients and the caregivers really is valuable. And so understanding those side effects, the treatment goals, and everything else is very important. Next slide, please. So when we approach pain, as I mentioned, it is individualized, and every patient, every situation is a little different, but there are some common pathways that we use and common approaches that I think anyone should understand. The first is, if pain's continuous, pain control should also be continuous. We often see, until there's a pain consult or a patient really starts to bring it up, the approach that most patients use is chasing the pain. If it's been a long-standing chronic pain, we'll often see that for years people use over-the-counter medications and just take them when the pain comes on, despite it being continuously, and then rises and falls. So if the pain is there constantly, there should be continuous pain control. If it is a new diagnosis, like I mentioned for cancer control or for other diagnoses after a fracture, start with a low dose but regularly scheduled, and then we can titrate regularly. So for example, hydromorphone dilaudid, like Tara Lee mentioned, is a good medication we can use. There's a short-acting version that quite often we would dose every 4 hours. And then from there, we'd start with a low dose. The first day or two, there might not be perfect pain control, but we can usually, over the course of a couple of days, increase the dose to find a reasonable level of pain control based on that discussion of what our goals are, where we want to get to. And then from there, we can convert the short-acting dose to a longer-acting dose in a lot of situations that will prevent individuals from chasing. There's a psychological component that goes with pain that if it's uncontrolled, like Tara Lee mentioned, for a long period of time, it makes it hard to get down. And there's also a fear factor. If patients feel like they're never going to have good pain control, there's depression, anxiety, sleep disturbances, all of which actually have a mechanism in our perception of pain going forward. And so getting that regularly scheduled dose removes the fear, allows individuals to sleep, gets rid of the anxiety, and can also therefore psychologically help the pain as well, even beyond that. Similarly to what I mentioned for categorizing the pain and deciding what makes it better and worse, if there's incidental pain with certain activities, if we know that we like to go for walks, or if we know that getting up or getting down or putting on clothes causes pain, there should be the availability to have a breakthrough pain management approach. If we are using opioids, quite often that's about 10% of the total daily dose at whatever interval is reasonable for your medication. So if we are using opioids, for example, hydromorph, a common dose would be 1 milligram every 4 hours, or that would be 6 milligrams per day. Therefore, a breakthrough dose would be anywhere from a half a milligram to 1 milligram. And that would last for about anywhere from 2 to 4 hours, depending on who you talk to, and then start to wean down. So knowing that there's an actual therapy that can be used that's effective is also very useful for residents. That way they don't fear those activities. They don't change the things that they love, because quite often we want to preserve that quality of life for as long as possible and to be able to do things where it's meaningful. And over time, you can decide what schedule that works for. So if it's half an hour, because the medication takes a bit of time to kick in, so you give the medication 30 minutes before the activity, the patient is comfortable and your loved one is also comfortable as well. And so kind of creating that schedule, having the plan in place of both continuous pain control and where necessary incidental pain control is really useful, even psychologically as well, to know that tool is in place. I'll get into more specifics of the adjunctive therapies, but quite often the top two pieces are with opioids, just because there are a lot of advantages with them for chronic pain or new cancer pain or end-of-life care as well. But the adjunctive therapies can either be non-pharmacologic or they can be targeting specific mechanisms that could be unique to the kind of pain that's happening. All of them have some degree of utility, but side effects need to be considered, and I'll go through one by one shortly. And then the most important piece, I would say, more than anything else, is because it is individualized, keep that pain diary, mark down what you feel is reasonable, ask pertinent questions, which Tara-Lee has gone over and earlier I went through as well. And the more you can kind of transition that day over day, document what works, what doesn't, when the medications are wearing off, when they're kicking in, all that helps to create a plan that will make sure your loved one or patients are better cared for and that they have a unique plan that's manageable for that situation itself. Next slide, please. So this slide is a bit busy and might be a bit small depending on how you're viewing it. And it is a little bit unique for cancer pain management, but it is gives people an idea of how we assess pain from a medical standpoint and what pathways they go down. So the pain assessment at the top is probably the most important because it gets a starting place to start. Until you have all that information to decide what's happened, why it's happening, and what the source of the pain is, it really makes it difficult to decide on a plan. Once you have that plan, then we start to look for, is there anything that can be done in terms of non-pharmacologic measures or mechanisms that might permanently alleviate the pain? Is there a surgery that should be planned that potentially could benefit? If we have stretching in some cases, if a joint's really compacted, or a massage that could release spasms, we want to go that route first just because it's a means that could provide some long-term stabilization instead of a therapy. But where medication then is necessary, usually we do start for at least cancer pain and a lot of chronic pains as well with an opioid therapy for a lot of reasons. I'll touch on slightly that I know opioids have a bad rap in the news, overdoses, and some people have their own experiences and addiction to go with it. But if it is an end-of-life pain management approach or a severe chronic pain management approach, it probably is the most effective therapy that we have once you get through those first two stages, simply because we have a lot of options. There's a lot of things that can be done to tailor it. And there's a lot more aspects in terms of safety and efficacy that we can approach, which I'll get to in a few slides as well. So opioids are there at the top of that chart once we get past those first steps, just because of those reasons I mentioned that I'll go through additionally. If we find that it's not doing a good job or side effects are inappropriate, then we start moving to the other classes. They all have their own benefits, but they all have their own limitations I mentioned. Some of the ones just quickly touching on anti-inflammatories or NSAIDs, that stands for non-steroidal anti-inflammatory drugs, can be really good for joint and muscle issues. But again, there are some side effects we'll have to consider. Similarly for nerve pain, sometimes nerve pain can be localized in the spine. Sometimes it could be something that's happening directly in the joint or in a muscle. It depends where it's coming from, but depending where the source is, we have a lot of medications that can be used. I'll touch on it a bit more, but generally the way we treat nerve pain itself is blocking the nerve transmission. And nerves are involved in signaling all over the body. And so quite often the main side effect of nerve pain medications is sedation. So it's always that balance between pain control and the side effects that go with it. And then lastly, as we move down the list, there's some other alternatives that we can look for, whether it be rotating. When we talk about opioid rotations, it's because either the side effects are limiting, or over time, sometimes there can be tolerance that's gained. So even though one opioid is related to another opioid, they're not 100% related. They are handled slightly differently in the body. And sometimes by switching from one to the other, you can gain benefits by doing so, especially if tolerance over time is one of the issues. So there are some unique properties from one to the next. And then the last is if we're not getting any progress, considering some anesthesia consults. Sometimes by doing a local pain block or an epidural can provide long-standing pain relief. And in that case, similarly, the psychological reasons, if you're not chasing it and you're not taking medications, you can just go about your life, it can be very useful. And so sometimes we don't think about that for home use, whether or not an epidural could be useful, but it is in some cases for chronic back pain or otherwise where anesthesia should be involved where needed. Next slide, please. So those medication classes, I touched on some of them so far in more detail than others. Opioids, I'll skip over for now just because we've talked about those a little bit in detail. Anti-inflammatory drugs or NSAIDs are things like ibuprofen or Advil. They can also include Motrin. There's a lot of prescription-based ones that many individuals might have tried. And like I mentioned, they are quite effective, especially for muscle pain, for joint pains. But the main limiting factor for them, which I'll get to in another slide, is that they can cause some side effects. The most common one, if you're using it long-standing, is ulcers. They can basically decrease the lining in the stomach, which opens that up. And so there's a risk of bleeds that can go with that associated. As well, there's certain conditions in the background they can worsen. One being fluid retention, how the kidneys get rid of the water. So both for people with liver disease, as well as heart failure or prior heart attacks, they might not be the best medication to use. So although they might be effective for pain, depending on what kind of pain you're getting, if they're going to be part of your regular management of pain, it should be something that's discussed with your physician, your nurse, your doctor, or pharmacist, just to make sure they're not going to cause more harm than good. That said, there are some situations where if they're used regularly to control the inflammation, or in some cases topically, some people use some topical versions that can be quite good, or even injections in some cases can be quite good. They're a great medication, just with some limitations we need to consider. Therefore, please consult a care provider if they're going to be a regular mainstay of your therapy. Acetaminophen or Tylenol is also one that many people are familiar with, readily available over the counter. And I would say for chronic pain, end-of-life pain, cancer pain, anything that has to do with caregiving for a loved one, is that Tylenol is usually not a good medication for incidental pain or as needed pain. It works best if it's used regularly scheduled. If you find that you want to try that to see if it's either an adjunct to opioids or as a first trial, schedule it every 4 to 6 hours. If you're using less than 2 grams a day, so that's 4 of the extra strength tablets or 6 of the regular strength tablets, there'd be no considerations for safety. So if you're below 2 grams, you'll never overdose anyone. There'll be no liver damage. I know it's something that people talk about on the news or otherwise. So 2 grams is kind of that rough number if you're starting at home yourself, where there'd never be any safety issues. Also considering that is it's 2 grams from all sources of Tylenol. So if you're using products like Tylenol number 3, or there's some other cough and cold products that have Tylenol, consider that in that 2 grams. If there's no liver issues or no other considerations after consulting with a care provider, you can usually get away with less than 3 to 4 grams without any issues either. But just in terms of a general rule, there's never any safety concerns if you're using less than 2 grams from all sources, which is again 4 extra strength or 6 regular strength Tylenols. Corticosteroids can either be oral, they can be injected. They're things like prednisone or dexamethasone. Some people also get an injection in their joints called triamcinolone or Kenalog. They help to decrease inflammation. If you are taking them orally, sometimes they can be quite good for even things like appetite as well. But they do have impacts all over the body. They can impact blood sugars. They can also impact, in some cases, delirium if the doses are too high. And they can also cause some bone and joint issues if used long-term. And so they're generally not a long-term solution unless they're localized, but they can be quite effective if we're looking for really localized responses like injections. And so a great therapy to look for if certain cases warrant them. Muscle relaxants or antispasm medications, similar to nerve medications, generally work by blocking a signal. And it's very difficult to block a signal from your spine to an area without causing systemic symptoms. So for both of these classes, the most common side effect is sedation. So if you go to things like Robaxacet, or there's some prescription ones like Flexeril or cyclobenzaprine, the main limiting factor is sedation. And quite often that sedation kicks in quite early. And so we have to decide, is the spasm something that we want to treat with medication, knowing that sedation is going to be the main side effect, and how that'll impact quality of life. Sometimes with non-pharm measures like hot and cold, massages, stretching can quite often work better than some of those oral medications. But again, case by case limitations that are there that we want to go through, knowing that sedation is a big factor. And if your loved one's sedated, they might not be getting the quality of life that they want. And then some of the others will go through cannabinoids, as well as there's some medications like ketamine that can be used in some cases as well. Cannabinoids now, with medical marijuana and recreational marijuana available in various forms, there's also prescription versions that over time have been developed that really target down what chemically they do and can be quite useful as well. So there are some prescription products that can be taken in pill form for cannabinoids, and that we know work quite well in some cases like spasms and back pain for MS. We also know in some cases those cannabinoids can be used for appetite, where appetite is declined. So there are some unique opportunities to consider if the other earlier classes aren't working well, and depending on what prior experiences are. I'll get to cannabinoids again to speak a bit more in detail, but some individuals have a lot of experience due to recreational pasts, or they've tried and they know it works well. And so very similar to what Tara Lee mentioned, if someone tells you that something's working well and they're happy with it, and we don't consider to be any safety issues and it's giving the quality of life, we really want to individually tailor things. So it's not our goal, it's not the things that we're choosing as the care providers. We want to make sure that it's meeting their needs and the side effects that they want are approached and dealt with appropriately. Next slide. So opioids, given that they're the mainstay, I want to kind of run through why we consider that, especially since there is a lot in the news to consider, and just having reports from one individual for another about why they might be bad. These are the reasons why we generally consider them to be good. There's a variety of options. There's about 6 to 8 different kinds of opioids that I'm aware of. They have some differences between them in terms of how the body uses them, how people approach them, and the way people also individually metabolize them. And so knowing that we have 6 to 8 that we can kind of work through means that we're not limited to one. It's not simply we try one and we have to move along. We have a variety of options we can use, and there are some differences in terms of side effects that go with those. If I use the example of morphine, Tara Lee mentioned itching or rashes sometimes that can come on with morphine. That's quite common because it has an effect on histamine, similar to what you would have with an allergic reaction, versus some others don't have that same reaction. Like hydromorph, we see it much less. We also see it much less with fentanyl. So if we get a side effect from something, we know just based on mechanism as physicians, nurses, pharmacists, that there's one we could use that doesn't necessarily have that characteristic and could be very useful. In terms of dosing, depending on what we're doing and side effects and activities, some medications are very quick acting. Fentanyl, again, is one that's been all over the news for overdosing. It's very potent, but kicks in very quickly. And with proper oversight and the low doses we're supposed to use, we can quite often get something that kicks in within 5-6 minutes and then wears off within 1 to 2 hours. So if you need quick onset dosing, there are options available, as well as we do have the long acting doses. So if we don't want to have to be taking a pill every 4 hours, we just want to move on with our life and know that pain is dealt with in the background, we either have the patches, like fentanyl patches, there's some other patches that are injected, or there's long-acting formulations that are twice a day. So take one as you wake up, take one as you go to bed, and quite often they'll last for those 12 hours and give a lot of freedom just to go about your life and to manage the pain without having to chase it as well. There's somewhat of a predictable response. So as I mentioned, we want to go start low, go slow, and we often start with the short-acting medications to see how the body reacts. Based on that, we can often predict the total daily dose and then move to other dosage forms where a reasonable level of safety can be had to adjust it up or down. Versus some other meds, if we only have one dosage form and 1 or 2 doses, what might work for one individual might not work for another. And so that dose might be way too high or way too low, and then we can't move from there. So knowing there's a predictable response and a mechanism to get there is very useful from both a safety and efficacy standpoint to know it's going to work for individuals. Also, as care escalates or changes, there's a variety of dosage forms, so we don't have to necessarily stop it. Some medications, there's only an oral form, or there might be only an injectable form. In various situations, it can either be oral, injected. In some cases, we can use sublingual dosing, which is giving a small, low volume drop under the tongue, or there's patches that can be used. So knowing that there's a variety of forms, depending on the situation, how care evolves over time, we can also use a variety of forms and keep care consistent, especially if we know that it's worked well instead of starting from scratch all over again. Opioids are generally reversible as well. So if there was the odd situation where something happened where an individual was seen to be getting too much of an opioid, it can be reversed. So there's an antidote called naloxone, or Narcan's the other name, that from a safety perspective, just knowing that there's an antidote or reversible factor is a great comfort for many caregivers, for the patients themselves, as well as for physicians, pharmacists that maybe in an emergency situation know what to do and how to manage it. Medications, especially as we age, change how the body breaks them down in metabolism. So there's different opioids that are broken down by the kidney, and there's others that are broken down by the liver. So if there was a situation where the liver was failing or the kidneys weren't working as well as they should be, we know which ones to use, and we can move from one to the other and still manage that accordingly. And then lastly, I kind of mentioned above with individual dosing, but there is short and long acting for convenience. So as we create those tailored plans, one for good baseline control, and then one for trying to approach with incidental activities or activities we want to continue for quality of life, it really is useful to know there is both versions, and so that we can treat accordingly and tailor according to plans. Next slide, please. So I mentioned some of these details, but just to make sure I documented them for adjunctive therapies, just to consider that every single one of them does have a unique side effect profile. So before we start them, even though it might have worked for a family friend, or you might have seen something on the news or read about it, it might not be appropriate depending on what side effects are also going to align with other conditions that are there, as well as medical conditions. Some of the common ones that might not bode well are things like liver failure or heart disease or kidney disease. And so every single patient is unique. We need to consider those side effect profiles as well as other medical conditions before deciding it's appropriate. I also mentioned that some of these medications are available over the counter. Tara-Leigh mentioned Gravol. Gravol, some people use for sleep, some people use it for nausea, but quite often it can be constipating, it can cause confusion, and it can also cause some other side effects which could be detrimental. So knowing that even though it might be working well, letting your caregiver know you've tried it, it's not judgmental, it's not meant to be to say we're going to slap the wrist, but we want to make sure that we consider all those aspects, and that sometimes there can be individual components that we might not be aware of until we fully go through it as a full team. Quality of life. So medications, as we go through them and choose them, they might treat a variety of other symptoms as well. I mentioned that sleep disturbances, depression, anxiety can worsen the perception of pain and also prevent pain from being treated effectively. There are some antidepressants that can be useful for pain directly just by the way they work in the body. And so if we know that there is depression or anxiety, we know there is pain, we might choose to use that as an adjunct medication versus something else. So cannabis is a big topic that I think everyone has some different opinions on. And I like to say that I'm pro cannabis in that I believe it gives us an extra option for pain. I think that whereas physicians, pharmacists, nurses have always been hesitant, is that lots of different statements have been made about what it's used for, how it should be used, or overstating that it's good for everything. And so I think kind of working through the situation, knowing that I'm taking it with a positive lens, especially for pain control, but different individuals might have different opinions, and that's fully allowed at this point while we work through it, and hopefully down the road there'll be more information. What we do know for sure is that cannabinoids or cannabis is involved in our physiology and the way the body works. There's certain hormones in the body that actually are involved with a variety of processes. So we make our own endogenous or our own systemic cannabinoids to help with a variety of processes, including pain. There's two main receptors in the body called CB1 and CB2 that sometimes, depending what you read, you might come back, and they have different functions for how they transmit different things and different processes in the body. So CB1 is involved in basal ganglia and brain areas involved with pain, stress, fear, and anxiety, versus CB2 is higher density in tissues and immune systems and the periphery. So sometimes people have talked about cannabis in certain strains being anti-inflammatory. Others have been talked about being used for sleep or pain or stress. And there is a difference in terms of where they work and what kinds of cannabinoids are involved. So THC, or the chemical name, is delta-9 tetrahydrocannabinol, and partial agonists against CB1 and CB2 receptors mean that they kind of work on both a little bit, but depending on how it fits, can have different effects throughout the body. So THC has that psychoactive effect of feeling high or euphoric, or sometimes blunting pain experiences can be involved. So muscle relaxant, pain control, relieving of nausea in some cases can be useful, or anxiety. But again, it depends on what dose are used and what strains are used. And because they're derived often from plants, they have a wider array of where they can be involved. And so similar we see with herbs and other situations, because it's not whittled down to work on one receptor directly, sometimes that can be very advantageous. Sometimes that can also cause a lot of side effects because it's working all over. So there's some positives and negatives by being widespread. CBD, or cannabidiol, is often talked about for being involved with pain as well as for inflammation, as I mentioned. So it's an antagonist at CB1 and CB2, meaning it can block them in those situations and inhibit the metabolism of THC into its psychoactive form. So sometimes having a small amount of CBD with THC can be advantageous because it allows the THC to stick around longer and do more. It doesn't have any psychoactive effects, meaning that less sedating or non-sedating doesn't really cause any confusion, and in some cases doesn't really help with that sleep piece that you're looking for. So if you're looking to avoid sedation, quite often CBD is more useful in those cases. Depending on who you talk to, quite often experts will say having a little bit of both, depending on the situation, is useful. So if you are looking to treat pain, higher doses of CBD with a small amount of THC, especially in seniors, is generally the approach that's taken when talking with some experts, versus having one alone without the other. Can be beneficial, but sometimes doesn't have the effects we're looking for. So again, there is a very physiological approach, a good scientific approach for where it's used, but especially when it comes to the plant-based forms, because it's not fully whittled down, it's not fully isolated, that has both risks and benefits, and that it can work all over. Next slide, please. So cannabis considerations, I think some individuals have experience of using cannabis from their own recreational days. And so they kind of know how they feel, they kind of know what doses to work, how much to use. But if you're using it for the purpose of pain or sleep or anxiety or any of those pieces, I think it's really useful to involve medical supervision. Although it can be obtained without a medical license, just recreational now in Canada, I think going the medical route is often the way to go. One, because it can be tracked. It's often put within the system of a team of a nurse, a pharmacist, a physician to know what's going on, and to also discuss just how it might interact with other medications or give some feedback where things are working and where they might not. Similar to other medications used for pain, the approach of start low and go slow is often the way to go. When you talk to some people, they say, use this dose or this worked well for me. And then because it's available recreationally, I've seen some situations where people have used too much, where it's caused some nausea and vomiting, or it caused some side effects they didn't want. And so working with a medical team, especially if you're using it for purpose of medical pain relief, sleep, anxiety, it's really useful to go that route. The pros of medical cannabis, in my opinion, is that one, it's very difficult to overdose. We have talked to some people where they might get that nausea and vomiting, but it's not the side effects that can cause physical harm, generally where the point where you'd end up in the hospital. So it does have low toxicity, and that gives us a lot of options to work through. There's a variety of dosage forms which we can use to titrate over time. So there's now capsules with CBD oil and a bit of THC that can start very low, and then over time we can create titration plans if you like the idea of using capsules. Similarly, there's the oils where you can start again at a very low dose and then gradually over time work your way up. It's useful to create a treatment plan where as a team you decide what your target dose based on what you're trying to treat looks like, and then start at the lowest level and so slowly work your way up. And once you find that level, then you stay there to make sure you have that balance between side effects and benefits. If you find that you never get the benefit that you're looking for, that's when you decide, similar to a medication that's prescribed, that you would stop it so that we don't just keep piling on medications that might not be doing anything. So having that plan in place of what you're trying to achieve, what a rough target dose looks like and how long it'll take to get there, just so there's expectations. If it's not working early on, we know what to look through. And then also to decide what that balance is again. So working through. The one piece that's been intriguing to me when I read some different papers and studies that go out is that there's a potential to decrease the dose of opioids. As I mentioned, opioids work really well, but they're always limited by side effects. So if you go to really high doses, you might get more pain relief, but quite often there's a sedation, there's a nausea, there's a constipation that really can counteract the benefits of more pain relief. So we want to avoid that. So there are some reports that have come out that by using low doses of cannabinoids or cannabis, you can lower the dose of opioids for a variety of reasons. And so if you can get away with a low dose of an opiate and a low dose of a cannabinoid or cannabis, then you kind of get the benefits of both sides without the side effects of both sides. So having that synergy that they work through two different systems that affect pain in the body, that could be beneficial long-term rather than just keep pushing the dose up higher and higher of one prescription class or the other. So it could be an and situation versus or, and in some situations where you do want to manage those side effects and lower the doses, but pain's an issue, cannabis could be something to discuss in some of those cases. In terms of side effects, what I mentioned before is that they do work within the system. We know with higher doses there are side effects, but because it's non-toxic, usually you can work through them. Higher doses, what we usually see is that dizziness, sedation, and dry mouth are probably the three most common that come on, and they usually are dose related. Sometimes it can also be strain related. So if you switch similarly from one opioid to another, switching from one strain of cannabis to another, you might not see the same side effects that are there. And again, by starting low and going slow, quite often you can avoid some of those feelings. Sometimes I've seen some seniors that haven't used, or patients in general that haven't used cannabis at all, they just don't like the way they feel on it. So they feel that dizziness or they feel like they're a little bit off. Again, you're going back to that quality of life piece where if it might be helping with pain, but you just don't feel like yourself, it might eliminate the benefits. So even though that's not a true side effect with THC, that euphoric feeling might be good for most people, there's some individuals that just feel like they aren't themselves, and therefore using it regularly might not be the best solution. Cost is still an issue as well. The majority of drug plans don't cover cannabis right now. The prescription-based ones that are just CB2 dependent, there are some drug plans that cover those, but they're less widespread as well. And so what I've seen for a vial of CBD oil is somewhere around $75 to $95, depending on what kind you're getting. And depending on the dose you're getting, that can last you about 1 to 3 months. And so the cost is not insignificant, and that has to be a decision that's made where if it is providing benefit and you want to go that route, you can. But similar to what I mentioned above, set a time frame for where you want to assess it, what your target dose looks like, and if it's not working, to either rotate to something else or to stop it, just because cost, let's face it, is an adverse event where if it's not working well, money isn't infinite. We need to consider that in the treatments we use. The logistics involved. So setting up the actual prescription, finding a prescriber, getting all those pieces worked out isn't as simple as simply seeing your doctor. It is getting easier in that there are pathways involved. And like I know our organization, because we're seeing more and more of it for long-term care seniors and seniors in assisted living, that we've tried to work through that to make it a little bit easier. But just because it is new in all the logistics and legalities with the government setting it up, there's a few more hoops to jump through than you would be simply getting a medication from a pharmacy as per usual. So I think just understanding that just because you say you want it, you see your physician and getting it, it might take a bit of time to actually get the medication. And the other thing that we see sometimes is sometimes supply isn't always readily available. It's getting better, but you might start on a certain medication that works well. And then there's been situations we've seen recently where it's not available and you have to switch to something similar, but not exactly the same. So again, those logistics are something just to consider, that because it's still a new process with the legal medical range of prescriptions for cannabis, that there could be some things to consider there. And I think the last piece that just is a con is the confusing messaging. So advertising, word of mouth, suggestion that's good for every ailment, I think it leaves people a bit confused over what they should be doing, how they should be approaching it. Everyone has their own experience when you start talking with them about what worked well. And because it's not as regulated with scientific studies to say, here's the dose we should be using for sleep, or here's the dose we should be using for pain, it leaves a lot of trial and error. And especially if you're using for the recreational end, it can lead to some cases of over sedation and some of those pieces that I mentioned already. Next slide, please. So that was everything that I have. We're open to questions again, since pain is individualized. I think the main summary from both Tara Lee's and my presentation, although I don't want to speak for Tara Lee, is that it's really useful to have those conversations, to document, to work through daily, and to create a plan that works for all sides. That clear communication and regular communication and documentation will not only help the relationship, to help to manage it and to maintain quality of life, but it also allows us to adjust when things aren't going well. And quite often, a lot of caregivers and patients suffer in silence because they don't realize what options are available. And pain can often be one of the most difficult symptoms to treat. And so hitting it early and getting to it early, like Tara Lee mentioned, and then having that plan really helps to manage and prevent the cycle that kind of goes forward.
So thanks, Mark. That was awesome. The one thing I can say about cannabis is in the long-term care setting, we have seen some success with our dementia clients. We know that antipsychotic medications can have many, many side effects, not necessarily good ones. And we've had some success with using the CBD oil, which is not affecting their mental function, but causing more comfort. And we've seen some success, and we've had people actually removed off of their antipsychotic therapy by using the cannabis therapy. So I wasn't an early adopter of it because I didn't like smoking and thinking of the old thought, but actually getting some education, as Mark has given us, is there's some good opportunity, particularly for cancer patients that are having a lot of difficulty with nausea. They've had some pretty good success in using the CBD oil or the capsules or whatever to really help people really struggling with nausea. So they don't have to smoke it. It can be in a pill form. So it's a new therapy. I do highly recommend that you actually go through your physician and go through the proper channels. You don't want someone going, here's some gummy bears, try it, because that's not regulated, and that can be very sketchy as to what's really in the products that you're trying. So have that conversation with your pharmacist and your physician. And so we're going to go to our chat now and just checking any questions that you might have around pain control or medications, anything that Mark and I could help you answer. We're ready for you.
We had some comments earlier just noting that ginger pills and ginger chews would be helpful for nausea, and just wanted to put that out there in case no one, someone didn't see the chat there.
So absolutely, ginger has tried and works for some people, and you always give something a try. And that's the herbal medications. For some people it doesn't work, for other people it does work. So certainly it is something that could be quite effective. So one person said, Mom likes to be high. I was thinking about it for increasing her drive to eat. So the old adage that, you smoke marijuana and you got the munchies, that really is true. It does help appetite. So it is a great thing to try if someone's really struggling and maybe they're feeling nauseated or maybe they're just really not feeling hungry. It's a good option that they could try. And for everyone, because we're humans, which is great, we're all different. It might work really good and someone goes, oh, it worked great for me. And you try it and go, really didn't work for me. But again, it's working with your physician and your pharmacist to try that.
Yeah, no, I agree completely. And we've had some great success. I think it depends on where the appetite decrease or reason for not eating as much coming from. When reviewing cannabis a few years ago for studies that were used for cancer patients, there was no actual weight gain with cannabis-based products, but there was some increase in terms of the quantity that was in the intake that was given from there. But that said, if, for example, if there's just not the joy in eating that there was before, or taste buds have changed over time, or a variety that's there, by all means, it's a viable product. And again, the same therapy would go where it's start low and go slow. So I wouldn't go right to the top and see what works. And a very viable therapy for both drive to eat, pain, and as well as in some cases for sleep if recommended. The one piece I would say for sleep is that we know that THC does change sleep patterns. So there's some medications that help individuals sleep, and there's some that you might be sleeping, but you don't get good quality of sleep, similar to with alcohol, which is why we don't suggest alcohol as a sleep aid. That THC actually has been shown to change sleep patterns where potentially you might not get the same restful sleep. So just something to consider as we work through it, that we're constantly learning. I think from what I'm hearing from Tara Lee, she's in the same boat as me, where if you're treating a symptom and cannabis works to treat that symptom, by all means, as long as it's safe and overseen by a care team, I think it's a valuable option for sure.
So the next question we have, Mark, is wondering if you're familiar with, I'm going to spell it, PSILOCYBIN therapy. And I'm honest, no, I haven't. Mark, have you heard it?
Yeah, I have it. And where we've used it similar to like a dissociative hallucinogen, or with similar like magic mushrooms. Some individuals have used it in low doses for anxiety, depression, sleep, things along those lines. I haven't seen great responses for pain. There's been some talk about whether or not it's anti-inflammatory. Again, the same thing goes where I think if you've gone down the proper pathways and nothing is working, then I think it's worthwhile to consider, but I think more needs to be looked at from there. So I wouldn't say it's on my treatment algorithm, but if someone brought it forward and we've gone through the proper pathways, I think to be discussed. Not truly legalized yet, unless there's something I'm not aware of, which is also the other piece why I can't recommend it.
I really appreciate it because I'm not familiar with it. So that's why I love working with my pharmacist. Will you be able to go up to the top of the, we've missed some of the questions. There we go. So I highly recommend it. I have taken CBD oil, Charlotte's Web, for the past 3 years and have great MRI results. So again, I really recommend that you speak with your pharmacist, you speak with your physician. There's lots of stores that are opening up, but making sure that they're going through a reliable, Canadian approved person. It is not your neighbor that goes, hey, I got this little bag for you. And it's not gummy bears that someone or muffins that they've made themselves. It's really important to have it properly regulated because you're taking the risk. Same thing is if I made the cookies, they're not the same as the store-bought cookies. So it's the same concept as you want to go to someone that is regulated and making sure that it's safe.
For the rest of the group, Charlotte's Web is high CBD, low THC strain. And so similar to what I mentioned above, if you're looking to treat pain, that's probably the approach that I would take, is high THC, high CBD, low THC, given that there's less psychoactive approaches and that there's a higher threshold in terms of safety, in my opinion, for a lot of patients going through that similar situation. So lots of different versions. The names are all fun to say, and depending on what you want to get, purple haze or whatever we want to talk about. So knowing that what's actually involved in the name is useful, and then choosing the right strain for what your condition is, or at least a good starting point. Because like I said, there's not a magic bullet that we've obtained for what should be used, what combination, what percentages for each condition. And so I think there's some general approaches we're learning over time.
We have one commenter here says, my husband is currently on prednisone for nerve pain as well as a lot of Tylenol 3. There's so many side effects. Would you like to try CBD? What strength and what am I looking for when I purchase this?
So I think that, from my opinion, the first place I would go is getting a consult with your physician to work through why exactly your husband's on prednisone. And I don't know the exact case. I won't want to through each situation, but the considerations there is that sometimes medications are chosen to treat a specific symptom, but there might be other reasons for using it. Prednisone can be used sometimes if there's cancer to decrease inflammation of a tumor, and that might be pressing on a certain area. And so we know that CBD, there is some anti-inflammatory properties. People will talk about terpenes as something we're working on right now. And they're basically, from strain to strain, there's these anti-inflammatory or chemical markers that have some effects. But if it's for a different reason that they're using a therapy, we need to be clear why it's being used. Similarly, if T3, the constipation, is not working well, Tylenol 3, a rotation to something else versus adding on a low dose CBD could be the case. But I think getting that consult, if there's not someone in your local area that can do the consult, though your regular family physician isn't involved, there are some clinics that are getting more reputable with time. I think early on there was a little bit of this, a little bit of that, where it wasn't reputable. But for example, Apollo is a nationalized group that we've used for some of our seniors in care homes to do like telemedicine consults. So they can do it over the computer, where they have a lot of experience to kind of work through. But I would also let your regular oncologist, physician, pharmacist know that you are going through it. So there's that communication piece. So I think that experience over time and making sure it's individualized to each case is where you would need to start from.
We have another one who says, have you ever helped someone who is a pill seeker, i.e. chasing the high from prescription drugs for pain? Would cannabis help?
I think that pill seeking is a difficult term to use because quite often it's linked with other conditions. So is there a mental health disturbance for why they're chasing the pills? Is it actually pain that's uncontrolled for why they're chasing the pills? Is there an addiction issue that they're chasing the pills? So I think finding out why that's happening and getting a proper consult and deep diving into is the first piece that goes from it. If it's a harm reduction aspect, there's many different theories on how to approach that. But if, for example, it's an addiction and you were to cut them off of an opiate and they're addicted and go to cannabis, they would probably go through withdrawal right away. So we've never used it for that approach. But at the same time, I think just starting from the same as with pain, you need to figure out why the pain's happening, the approach from it, and then work from there. So I haven't specifically used it for that purpose of harm reduction, but depending on why they're pill seeking, could there be a purpose? Sure.
Perfect. So those are the questions that we have. Any other questions that you're thinking of? You've got Mark and I, so we're here for you in case you have any other questions for us. So one of them is that mom loves her wine. So true. So my father just passed away. He was 91 years old and he loved his little drink, and he went to diet pop because they were worried at one point about the sugar content. But my mom was like, oh, he's starting to get confused because he started to get dementia. She's like, maybe I should stop. And I'm like, Mom, are you worried that he's going to live 20 years and become an alcoholic? Oh, no, then it doesn't matter. Just make sure he does it at the end of the day so he's not at risk for falling because he's had his alcohol. So what makes you happy is what's really important. If you're a chocolate lover, then enjoy your chocolate. If you love your alcohol, it's a drink. It's not 5 drinks. But enjoy what they love. Just make sure it's in the safe zone. So a lot of people will have their wine at supper, which is really good. You're getting food at the same time. But what they love, that's what's more important in life, and let them enjoy it.
One question here asks, do you know if professionals at the Seniors Health and Wellness Center would suggest CBD THC products for my mom? She has an intake coming up.
So I'm not personally aware of the resources at the site. If Tara leaves, I'll let her speak first, but I can go to a general approach if she doesn't. No.
Right. So I know that your Health and Wellness Center has lots of different resources. And that is a good question that you need to be asking and going, I've got some questions around this. I had some education around this and went, is this appropriate? Could this be a possibility? It's always taking it back to your physician. Your pharmacist is another great resource for you. But certainly ask those good questions. I always write my questions down before I go into those centers, because you get busy talking about one thing and you walk out and go, I forgot to ask about this. So I absolutely would bring that up and go, is that an option? And as I said, I've had some good success. Not 100%, but I've had some good success with seniors with dementia and having behaviors and difficulties and agitation. And the CBD, it worked. And we weren't early adopters. We weren't like, oh, what are we doing now? But we've seen success. So it doesn't work for everyone, but it's worth an option. So that's my 2 cents.
What I would, just because there's an intake coming up, what I would say is that each care home has their own policies and procedures about medical cannabis and cannabis in general. For the most part, most centers won't allow inhaled cannabis or any vaporized cannabis, and a lot won't allow any topical forms just because it's unpredictable, or edible gummies. So it's usually the capsules or the oils are what a lot of facilities will allow. But again, facility is different. For CareRx specifically, just because we specialize in long-term care and assisted living, we've partnered with Spectrum Therapeutics, which is a branch of Canopy. The reason for that is the variability of response and companies coming on the market, then folding, and then finding out that their therapies weren't effective or not saying what they wanted, or in some cases having fungus. So we wanted to go with someone that actually had a long-term care division. So with Spectrum itself, they're adherent to the policies the sites have, and they often do have the consults with Apollo available. And so if it does come up that you're looking for something and there aren't resources available, at least that's a starting place for some individuals. I don't get any money from them, so there's no pitch, but it's simply that we found that for seniors specifically, they have a branch that is trying to work towards some of those solutions, because it's still an evolving market, where if you did want to look into it, it's called Spectrum Therapeutics, and they're a branch of Canopy. So at least that there's that alignment for seniors care and some of the restrictions that many of the care homes do have.
Absolutely. And I've actually gone to their website. It's a great resource for looking at the options and how that can support seniors. The next question we have is, she gets so itchy, I give her half a dose of her allergy meds. So number one is side effects of medications. It could be side effects of the disease process that's causing the itchiness. As I said, with every wash, it's always applying lotion back on. As we age, our skin dries up. It's just part of our normal aging process. So itchiness can be very common for many different reasons, but always use some good lotion to really support that. And Mark, do you have anything else to, I'm always worried about allergy meds because they have good side effects too, and they can cause some sedation. So I love that you're doing half a dose. I think that's great if that takes away the itchiness. It's something that you might want to do at bedtime because it does have that sedating effect. And people sleep. And as you sleep, it's amazing what your body does. And you wake up in the morning and go, how did I scratch that and made it bleed? Because they're sleeping and it's irritating them. So it's a good thing that someone is having itching problems. If you're having to give them something to help with the itchiness, it's good to do it at bedtime too, to keep them settled while they're sleeping.
Yeah, the emollient piece, we don't even realize we're dry, and itching is quite often a big piece. And there's also the misnomer that lotions are moisturizing. Quite often lotions are drying. And so finding the right moisturizer, like a CeraVe is a good one, and trying it regularly is usually a big benefit. In terms of allergy meds themselves, typically we try to avoid Gravol and Benadryl in seniors just because they cross into the brain. And that can cause the sedation piece, but also the confusion. And there's some other symptoms we call anticholinergic that can contribute to falls. And so we try to avoid them. It can cause blurred vision that sometimes seniors don't talk about. So if we are looking to use an allergy medication in a senior because the itching won't go away, quite often we'll try what we call the second generation ones, which are things like Reactin I'm trying to remember, my brain's not working for all the brand names, but Reactin's one that's out there that's a second generation, or talk to your pharmacist, that they generally don't cross into the brain, but still have the same allergy relief if they're used regularly. They sometimes don't kick in as quickly. So if it's something that you see for mom that's daily and you need to use it daily, it might be a better option. But again, each case is different. Talk to your pharmacist, talk to your physician.
Our inspiration segment is to be inspiring, thought-provoking, empowering, and allow us to be curious with ourselves. Today's inspiration speaker is Sharon Hughes-Geekie. Sharon has spent 12 years as Area Director, BC Interior, with a national home healthcare company. Today, she is the owner of Jumpstart Communications and Business Development and co-author of Mama's Gotta Work. She serves as healthcare representative on the Central Okanagan Economic Development Commission's Advisory Council, is vice chair of the Okanagan branch of Women in Leadership, and her latest co-author project, Fearless, arrives in bookstores in March.
The topic today is enabling wellness, and that is the goal of family caregivers. Next slide. So when we talk about wellness, we're talking about an active process which people become aware of and make choices toward a successful existence. Now, that changes over time. What is a successful existence at the beginning of a diagnosis or the beginning of aging changes. And so it's constant new information that you're navigating. And that's the challenge for family members, is that things are a constant moving target. Next slide. So my parents passed away in the last 2 years. My dad passed away 2 years ago and my mom passed away a year ago. And my dad had, prior to his passing, my dad had a form of blood cancer, and my mom broke her hip the day before their 60th wedding anniversary and ended up in facility care. So as a family, my siblings, my brother is younger than me and my sister is older than me, had to navigate the care process. Now, as Natasha alluded to, I have spent a lot of time in healthcare, and I've worked with hundreds of families, helping them navigate care decisions and all the things that families need to think about. And I have to tell you, it is totally different when you are doing it with your own family, because with family dynamics is decades of baggage and differing personalities and differing relationships with my parents. And so what I might have thought was a good idea, my sister didn't feel was a good idea. And so it was a constant give and take, trying to navigate what was best for my family. So when my parents were diagnosed, my dad was initially asymptomatic, and so he was able to go visit mom in the nursing home every single day. But as his condition deteriorated, my sister took over that responsibility, because my sister and brother live in Calgary and I'm one of the faraway caregivers. So we did a lot of navigating, and some things we did very, very well, and some things I really view as missed opportunities. And so this is our journey, and everybody's journey is different, but these are some of the things that we think that we did really well and you might want to consider in the future, and other things I'm hoping you will learn from. Next slide. Validate, a life well lived. Reminiscing is a wonderful opportunity to connect with your family member when it's really hard to talk about things. And it allows them to talk and think about the good things that happened in their lives and move forward, feeling good about what they've accomplished in their life. One of the things that I tried to do whenever I was reminiscing with my mom or my dad was to ask questions. What was their greatest accomplishment? What were they most proud of? What were the moments in their life that really stood out? With my dad, it was really interesting because he grew up on a farm. He was very, very poor, and he ended up with a master's degree, which he was incredibly proud of because it was such a difficult journey to get there. My mom, a very different person, was a stay-at-home mom and happy with her life, not a doer or highly motivated. She was happy to be at home raising her children. And when asked what her proudest moment was, she was in a piano contest as a young girl and considered to be the loser in the contest. And she came out on top, which she was incredibly proud of. So it's those moments that they remember, and it makes their lives, it puts it in perspective that even though they're going through tough times, they had a good life, and they're able to think back on that and feel good about their accomplishments. Next slide. So we do a lot of celebrating. I have to tell you that my family is a family of sugar addicts. We celebrate with cake constantly. My dad turned 90 8 months before he passed away, and we wanted to give him a celebration. He was still feeling pretty good, and we wanted to have a party for him, invite all the relatives, and give people a chance to actually spend time with him. My dad is not a person that likes attention, and he was adamant that he didn't want a party. So my uncle, who was 96 at the time, that's the gentleman sitting on your right, he phoned up my dad, who at that point, my uncle was also aware that my dad had a terminal disease. So he phoned up my dad and he said, look it, I want a party. We go to funerals all the time at our age. I want to be able to celebrate this special moment with you. I want you to have a party. So my dad decided that it would be a good thing to have a party for my uncle's sake. So we moved the party to Wetaskiwin, 2 hours from Calgary, where my uncle lived. And we planned the party in Wetaskiwin so that my uncle could be there and it was closer to all the relatives. It was an amazing day. And what made the celebration so special is that it enabled us to tell my dad the good things that he had done, the difference he had made in our lives, and the things that we were proud of him for, and not wait for a eulogy at a funeral. So it was a very, very important moment for us. And it was something that made Dad feel very special. And again, it put his life into perspective and he realized how much he was valued. Next slide. Support. So this is one of the things that we didn't do so well. My dad got his diagnosis and they told him as he started to deteriorate that he could go for chemo. Now we asked very clearly what the outcomes were, and they said it might prolong his life for 3 to 6 months. But there were side effects to the chemo. So again, it's different family dynamics and different perspectives. So my perspective, having been in healthcare, was that chemo can be very destructive. I have seen clients go through terrible times with chemo, and it was not a good way to spend their last days. My mom and my sister felt very strongly that my dad needed to do everything possible in order to survive. My dad was kind of the mind that he really wasn't keen on chemo, but he didn't want to disappoint my parents or my mom and my sister. So I said to him, you don't need to do this. You need to do what's right for you. And he said, well, you know what? I don't want your sister and your mom to be upset with me. So I will try chemo. And if it doesn't work, I can always stop. So that's what he did. It was terrible. He went from being active and mobile to being very weak. He would moan all the time. He was in terrible pain and he was exhausted. He stopped eating. He lost weight. He needed more blood transfusions. It wasn't a good course of action. But again, he did it because other people were counting on him to do it. And that happens so often that we are so convinced that survival and having a few more days with the ones we love is more important than quality of life, because in our heads, we know that a person is dying, but in our hearts, we are always holding out hope. And so my recommendation is that you get all of the information about what outcomes look like, and you ultimately let the person decide. If they're of sound mind, you let them decide what they want their life to look like at the end, and whether that's taking aggressive treatments and hoping for the best, or whether it's, having a less invasive care regimen and enjoying a few more moments with family. That's something that your loved one has to consider. And if they're mentally capable, they need to have support in their decision. The other thing that I will tell you is that planning physically and mentally for the worst case scenario is very, very depressing, and it's very, very hard, but it makes a huge difference, because if you wait until what you hope will never happen does, you're in a position where you're overwhelmed and you're not able to cope, because suddenly you're feeling terrible about the situation and it all seems so hopeless, and you're devastated and have a tougher time coping than if you'd planned in advance. The other thing is to be honest about your limitations as a caregiver. Now, when my mom broke her hip, my dad was still fairly asymptomatic, but he was weak, and he knew that there is no way that he could look after my mom when she couldn't toilet herself, she couldn't dress herself, she couldn't get in and out of a chair by herself. So he said, when the doctors told him that mom could go home, he was adamant that she couldn't go home, that he couldn't look after her, and that it wasn't something that he was willing to entertain. And so he made the very, very difficult decision, and something he felt guilty about forever, about having her go into a nursing home. And again, it was a difficult decision, but it was the right decision, because he clearly couldn't have looked after her on his own, and she wasn't about to take care from anybody outside of the family. So it would have put him in a position where she wasn't getting proper care and he wasn't taking proper care of himself. Next slide. So you're always looking for ways of making things better for your loved one, and nature and animals really are helpful. Getting out for a walk in nature is very therapeutic. You know, if they have pets, being around their pets. If they don't have pets, bring your own animals over for them to visit for short periods of time. The other thing too is not only being in nature, but looking after a living thing. In my mom's case, she had a roommate that loved plants. She was in a wheelchair. She couldn't possibly look after plants, but our family used to take her plants all the time and we'd water them for her. And she would tell us every day when it had a new leaf or whatever. And it's because as human beings, we want to be useful. We want to look after something. We want to make a difference. And by having a plant, you know, even just being able to water it or watch it grow makes you feel useful, and it can be very therapeutic. Next slide. So peace of mind. This was another thing that we didn't do so well. My dad was a planner. He knew exactly what he wanted in his life, and everything was set out. He had lists for when he died. He had lists of who to contact, where the funeral arrangements were to be made. He had lists of everything that you needed to do, government contacts you needed to make. He had a step-by-step guide as to what to do when he was ready to pass. Now, it was probably 2 months before my dad passed away that we were sitting in a restaurant, my brother and my sister and I, with my dad. And my dad, out of the blue, said, you know, I think it's time that you all start looking for a casket. Make that arrangement because I think it's time to get that done. Well, my sister, who was very, very close to my dad, burst into tears and said, no, we are not going to talk about this. You've got lots of time left. It's too soon. We don't want to even discuss this. Now, her reaction was authentic and it was very real, and it came from a place of love and perhaps denial. But what it eventually did was, again, my dad wanted to please. And so he didn't want to talk about anything that was going to cause his family pain and suffering. And so he didn't talk about that again. Now, the problem with that is that it would have given him peace of mind to know that that arrangement was done. It also would have given him control over the final stages of his life. And it also would have been an opportunity for us to bond as a family and do something together and make decisions together and bring us a little bit closer together and open those lines of communication so that my dad felt comfortable talking to us about anything during the final days of his life. So I feel badly that we didn't do that. And in retrospect, again, family dynamics got in the way. You know, if it had been an objective person from the outside of the family who had helped us to navigate that, I think the conversation would have gone a little bit differently, and my sister could have left feeling a little bit better about things, and my dad could have gotten the closure that he needed. Next slide. So the other thing that my dad did when he made his plans, and he sat down and had a meeting with us probably 2 years before he passed, was that he decided what he wanted for his funeral, and as did my mom. And my mom wanted a full funeral, and my dad wanted a graveside service with only immediate family. So my mom is a person that likes to be in control, and control is very, very important to her and has been her entire life. So when we went to talk to mom about the service, once my dad passed away, my mom said, you know, you've got to talk to the minister about a funeral. And we told my mom that dad didn't want a funeral. He only wanted a graveside service. My mom was outraged. And she said, he did this behind my back. He lied to me. He didn't discuss this with me. And we said, remember, mom, the meeting that he had? He was very clear. He wrote it down. That is not what he wanted. So we were caught in a place where we wanted to honor my dad's wishes, but we also didn't want my mom to have this ongoing anger and grudge against my dad, who she had passionately loved for over 60 years. So we had to come up with a way of fixing things. So what we ultimately did was we had a celebration of life in the church, but not in the sanctuary. We had a sunroom, beautiful April day, brimming with sunshine. We sent notices around to the neighbors. We put it in their mailbox, and we invited friends and relatives. And we said, we're just going to have a celebration of life. There was no minister there. My brother and my sister and I all talked about the good things my dad had done and told stories. And, there were no hymns. My dad loved poetry, and he was a gold panner, and we played the cremation of Sam McGee with Johnny Cash, because at 88, he'd gone to the Yukon to pan for gold, and it was his lifelong dream to stand on the marge of Lake LaBarge where they created Sam McGee, and that's exactly what he did. And so that was one of the songs we played. It was an absolutely beautiful afternoon. People left and said what a good time they'd had, which is not something that you ever hear at a funeral. So we felt that we had done a good thing. It was absolutely packed. We were thinking 30 or 40 people, and there were over 100. We violated fire regulations, but it was an absolutely wonderful tribute to my dad, and it made my mom happy. And it still respected my dad's wishes that he didn't want a church funeral. And again, control is so important. And as people age and illness sets in, there's a loss of control. And rejecting care is a way of exhibiting control. And that is certainly what my mom did. In order to be able to go home, she needed to do exercises, and she refused medication. She refused to go down to dinner. She refused to do all of those things because it gave her control. And we felt that if we had not done something to help her through Dad's death, that would have escalated. In actual fact, what happened was that after my dad passed away, she wanted to go home. And we said to her, nothing has changed. There are 13 steps to get into your kitchen, and you're not able to do that. And in order to do that, you need to exercise. So my mom finally, stubbornness kicked in, and she said, okay, I am going to exercise and I am going home. And we said, well, we could get you into a condo, or we could put a lift into the house. She goes, you're not damaging my house, and I'm not living in a condo. I'm going home as is. And that's my plan. So all of a sudden she started exercising, and she started doing regular efforts with the therapist, which you see in that picture, who was a wonderful human being. And my sister made a little box, and she would do steps at her chair so that she would lift her feet on and off the box. And one day we were working my mom at the bars, and my mom said, I'm going up the flight of stairs in the nursing home. And we're like, well, Mom, that probably isn't a good idea. And she goes, no, that's what I'm doing. And so the physiotherapist, bless her soul, said, okay, let's try it. So they took Mom into the stairwell, they parked her wheelchair, and she made it up the flight of stairs. We got her a chair and a glass of water at the top, and she was as proud as can be. And for her, it was a huge accomplishment. And she wasn't a person that had huge accomplishments throughout her life. And she was suddenly the talk of the nursing home, and she inspired others. Others saw what she was capable of, and they wanted to have that same opportunity. So it was a huge problem for the physiotherapist, because suddenly she was inundated with requests for help. But though my mom never made it up the stairs again, and she declined after that, and she never did make it home, it was one of the proudest moments in her life. And for that, I am incredibly grateful, because the more independence people have, it increases wellness, and it gives them the confidence to do more. And that was certainly the case with my mom. Once she made it up the stairs, she thought that there was no stopping her, and she truly believed that she would eventually go home. Next slide. Your role as a family caregiver is not to enable your loved one to survive. It is to help them to live their best possible life in the time that they have left. Being a caregiver is very, very difficult. And we had it relatively easy. We had a very closely knit family. My sister and brother and I agreed on most things. We were able to compromise on most things. And my parents had done careful planning for their golden years. So it wasn't as much of a struggle as some people have. Everybody has a different journey. And, I'm grateful for the journey that we had, and I'm grateful for my siblings and the role that they played. I'm particularly grateful for my sister, because like most eldest daughters, she took the lion's share of the work. And it was a struggle for her. And for that, both my brother and I and my parents are extremely grateful. Next slide. But looking after yourself needs to be a priority. And that is something that you constantly need to look at, ways of taking that time for yourself, ways of connecting with your friends, connecting with the people that you like, doing things, learning things. Don't put your own life on hold to care for somebody else, because those experiences, as I talked about in my first presentation when we started this education series, is that those experiences are what move your life forward. They are what living is all about. And if you give up those experiences, your life is on hold and you're marking time. And those experiences that you have, those new experiences that you gain and the things that you do, it gives you something exciting and new to share with your loved one who may not be able to enjoy those things. Thank you very much.